Okay? All right. So, when we talk about respiratory issues, and this is in the newborn or in anybody, okay? We have to think about respiratory distress is just a manifestation, okay? And some causes of respiratory distress have nothing to do with the respiratory system. The majority of respiratory distress does have to do with the respiratory system. But you also have to worry in your differential diagnosis about other things that can manifest with respiratory distress. So respiratory distress, tachypnea, nasal flaring, retractions, grunting in the baby, okay? Sometimes cyanosis, whatever. That can be caused by a variety of processes. The non-respiratory ones can include cyanotic heart disease. So if a baby had a little something in the back, been talking all day, so if a baby has cyanotic heart disease and is going into heart failure, many times some of the things you see will be respiratory distress. Either end of the spectrum, anemia or polycythemia can be a load on the heart. So even though you don't have congenital heart disease, you can have heart failure from anemia or polycythemia, and that can manifest with respiratory distress. So you have a list of other things, infections, okay? So for example, actually the little baby that I referred to earlier that came in last week was having apnea. Not so much respiratory distress, but is having apnea. Okay, and the baby ended up having an infection. See, I've given you another clue. We'll get to that baby later. Metabolic issues like hypoglycemia. Metabolic issues like inborn errors of metabolism. Okay? Inborn errors of metabolism cause a metabolic acidosis, and to compensate for that metabolic acidosis, you breathe faster and you can develop respiratory distress. Neurologic issues like a bleed can cause respiratory distress. However, the most common causes of respiratory distress in anybody, including the newborn, are respiratory in origin. And those are listed there are the big three that we're going to discuss. Respiratory distress syndrome, transient tachypnea of the newborn, and Meconium aspiration syndrome. The littler three include pneumonia, diaphragmatic hernia, and choanal atresia. Okay, and we're going to kind of discuss some of these, especially the big three. Shortly after birth, a 33-week gestation infant develops tachypnea, nasal flaring, and grunting, and requires intubation. Chest radiograph shows a hazy ground glass appearance of the lungs. So Rekha is saying ground glass equals RDS. Okay, that's the last clue. What's the first clue? Very good. Kavita, Preeth, Faisal, Denise, Preeth again. Preeth is hungry, wants 2 chocolates. Gloria Daniela. Okay, 33 weeks is the first clue there. The first clue is the age of the baby. Okay, so when you're approaching another pearl, when you're approaching a test question, when you're approaching real life patient, the age of the patient and the sex of the patient are extremely important in your differential diagnosis. Okay? So the first clue here is the age of the patient. First of all, shortly after birth. And the baby it was a 33-week gestation. It was a preterm baby. Tachypnea, nasal flaring and grunting, those are just generic things that you see that tells you that there's respiratory distress. The ground glass appearance is the next huge clue for RDS. So RDS occurs when there is a lack of functioning surfactant. There's an inadequate amount of functioning surfactant. That's another tiny baby. So when there is a lack of adequate amount of functioning surfactant, surfactant is responsible for maintaining surface tension or decreasing surface tension so that your alveoli don't collapse. If you don't have enough surfactant that works properly, the alveoli collapse and you start developing atelectasis. And depending on how much atelectasis you have, that determines the onset of signs and symptoms. So if at the beginning you might have actually good APGAR scores, because the APGAR scores could be, it's only at 5 minutes, and the baby may not reach that critical mass of atelectasis until half an hour and a half. It depends. And they start having these signs and symptoms, okay? So, it is a deficiency of mature surfactant, and so you cannot maintain alveoli, and you start having atelectasis. And when you get sufficient amount of atelectasis, then you have all the manifestations. They will decrease their functional residual capacity, which is where oxygenation takes place. They'll get atelectasis and they'll have hypoxemia. The grunting that occurs is the baby trying to actually basically doing a Valsalva maneuver to help try to keep open the alveoli. But now they need to take a breath. What they do is they close off the vocal cords, bear down, and they're trying to keep alveoli open. But they need to take a breath, so they'll go, and you'll hear grunting. Okay? That's a bad sign. So I said hypoxemia, secondary to the atelectasis and the shunting. They will develop a respiratory acidosis. So they might give you a blood gas to interpret. This is the classic. This isn't too bad. Okay, this isn't too bad, but you can already see some stuff coming up this way, and you can see some air bronchograms. Okay, you can see these little black lines just kind of coming out. Those are air bronchograms. There's atelectasis around those smaller airways. And as it gets worse, you get more and more collapse and more of a ground glass appearance. So that's a huge clue. So here, now you're starting to see, look, the whole left side is becoming obliterated. You don't see a good heart border over here. There is a good air bronchogram. This baby's been intubated. Okay, baby's been intubated, but you see a good air bronchogram here. There's some more coming down this way. There's another one going up that way. Those are air bronchograms. Okay? And the best test is a chest x-ray. Okay, once the baby is born and they're having the respiratory distress, the best test, the best initial test, sounds like a test question, is a chest x-ray. Okay? And you'll see those findings. Before the baby is born, you can do LS ratios. Once the baby is born, who cares? That's right, Rekha, but intubation is not a test. So you have to be very careful when you read the question. So the best initial test is a chest x-ray. If the baby is having severe respiratory distress, the first initial thing to do is to intubate the baby. And many times what they do is they will intubate the baby and they will give surfactant. Okay? So this is the same concept, and they've given you 3 different ways of asking it. So they can describe the baby and with the same stem, okay, the same stem. In step 1, they would ask you, what's the underlying problem? And you'd have to say that there's not enough surfactant. And then they might say, what cells are responsible for producing surfactant, whatever. On step 2, they'll ask you to make the diagnosis. What's the most likely diagnosis? Or they'll say, what is the best initial test? Okay. And in step 3, they'll say, what do? You intubate the baby. So the question coming up now, what are the weeks of gestation limits for giving surfactant? If the baby is preterm, which means less than 37 weeks, you're game to give surfactant. Because even at 34 weeks, that baby may not have enough functioning surfactant. 32 weeks, absolutely. Okay? So even at 36 weeks, that's a preterm baby. And that baby can have RDS, you would give surfactant. Okay? So the clue there is the fact that it's a preterm baby. In respiratory distress, the most likely cause is respiratory distress syndrome from lack of sufficient functional mature surfactant. Okay? Response to therapy, breath sounds might get better, oxygen requirement is improved. Okay? All right. So, give the baby oxygen, intubate the baby, and give surfactant. Okay? And actually the best thing in the management of RDS is to prevent RDS. So how do we prevent RDS? The best way to prevent RDS, Sylvia is typing something. A bunch of people are typing something. You're so close. But the best way to prevent RDS, tocolytics. Denise! Chocolate for Denise! The best way to prevent RDS is to get the pregnancy to term. Okay? So by getting the baby to term, you avoid that because the baby has a chance to develop enough mature functional surfactant. Denise está en fuego. Okay? Está en fuego. Now, preventing the baby from being delivered. Okay? While you're preventing that, you can give steroids. Okay? So the first thing is to give tocolytics. You can give steroids. Once the baby is delivered, you don't need to worry about steroids or tocolytics. Now you do surfactant. Okay? So prevention is get the baby to term, antenatal steroids. Once the baby's delivered, surfactant and supportive care. Now some of the stuff I'm giving you is step 2 material. Some of it is step 3 material. Kaplan is very nice. Kaplan is not going to charge you extra for these little step 3 pearls I'm giving you. Okay, but don't let them know I'm doing it. Okay, these are freebies. These are freebies. Okay, but by the same token, I'm giving you some freebies for step 3, which lets you know that the step 3 review course is awesome. Okay? Awesome. So keep that in mind after step 2. All right. The next one, So we said the big three were RDS, TTN, MAS. It's like alphabet soup. So the next one is known as transient tachypnea of the newborn. The clue here. Oh yeah, I give step 3. I give step 3. You better believe I just gave step 3 like a month ago. So TTN, transient tachypnea of the newborn. First clue, look for a term baby. Second clue, look for a rapid second stage of labor, okay, or a C-section. The baby is not getting that vaginal squeeze, and therefore there's going to be some amniotic fluid just kind of hanging around, okay, and they will start breathing faster, okay. So first clue, term baby. Second clue, C-section or rapid second stage of delivery. Most of these babies have respiratory distress and they will have a minimal oxygen requirement. And look at the chest x-ray. It's also the best initial test. Oh my God, I'm giving away so much information today. All right? So it's also the best initial test. And in this case, look at the difference between that x-ray and the one we saw earlier. Nice, clear heart border. Sometimes you'll see a little bit of fluid in the fissure, like between the right upper and right middle lobe. But typically, it's a normally looking x-ray. And these babies, supportive care, and they get better on their own, okay? You may not see it on this x-ray. Sometimes you do see it on x-rays, okay? But typically the x-ray doesn't look very bad. And they certainly won't have the magical ground glass appearance, okay? So first clue, term. Second clue, rapid second stage or C-section. All right? All right. I sound like Matthew McConaughey, huh? All right, all right, all right. Except I'm not on anything. I'm not on any stuff. Okay. The next one is, I'm just high on life. Meconium aspiration. Thank you very much. Meconium aspiration syndrome, MAS. Okay. Clue. First clue. Look for a post-term baby. Okay. Or another huge clue. Okay. I love it. I love that. Okay. Another clue for meconium aspiration syndrome is when they rupture membranes. Okay. When they rupture membranes, they'll describe meconium. Now, meconium is baby poop or fetal poop. Meconium is fetal poop. And for the most part, babies, fetuses, don't pass meconium in utero. If you have meconium stained amniotic fluid, you should be suspicious for some kind of event in utero. Okay? Some kind of event in utero. The baby is stressed, relaxes the sphincter, passes meconium, it's in the amniotic fluid. When the baby is delivered and it takes a breath, that meconium stained amniotic fluid that's sitting in the upper airway gets aspirated. Now, light meconium is not a big deal. Thick meconium is a big deal. Okay? Thick meconium is a big deal because it just gets into the lungs. It causes an aspiration pneumonitis. And meconium is really sticky stuff. All right? And it causes an aspiration pneumonitis. The baby will have respiratory distress. And once again, the best initial test, just x-ray. Okay? It won't look like ground glass appearance. Okay? Ruptured membranes. What we're talking about, Thanmayi, on ruptured membranes is when they ruptured maternal membranes. Okay? When they rupture the membranes and the amniotic fluid comes out via the birth canal, you'll see thick meconium. Okay? All right. So, the baby's delivered, has respiratory distress. The best initial test is a chest x-ray yet again, but you don't see a ground glass appearance. Okay? It's more of it's like an aspiration pneumonia. It can go anywhere. Here you see look at this side. That doesn't look too bad, but over here it looks different compared to this side. The heart border isn't as clear. So there's an aspiration pneumonia here. Okay, so clue. The first clue could be gestational age being post-term. So there's a higher association of post-term babies with meconium aspiration. But a bigger clue would be meconium when they rupture membranes. Not so much because of oligohydramnios, but because sometimes these post-term babies are stressed and they pass stool. Okay? And again, the best initial test is the chest x-ray. So what do we do about it? Because what does meconium aspiration syndrome do? Well, meconium aspiration syndrome causes a lot of hypoxemia. And hypoxemia in the lungs causes pulmonary vasoconstriction. Pulmonary vasoconstriction increases the pulmonary vascular resistance. And therefore it's harder for blood to get to the lungs, and blood will then shunt, okay, deoxygenated blood shunts across either a patent foramen ovale or a patent ductus arteriosus. That, in turn, causes more hypoxemia, which then causes more vasoconstriction, which causes more pulmonary vascular resistance, which causes more shunting, and we call that pulmonary hypertension of the newborn. And we used to call it persistent fetal circulation. And meconium aspiration can lead to that. So what's the treatment? Well, first of all, we want to prevent. We should always flip-flop these. Prevention is more important. When the baby's head is delivered, even before the baby starts to cry, when the head is delivered, good suctioning of the oropharynx with the bulb suction will help. Okay, now this is more of a step 3 freebie, but it might be in step 2, okay? If there is thick meconium, you do endotracheal intubation, okay? Endotracheal intubation and suctioning of the airway, but only with thick meconium, okay? So deliver the baby, suction the oropharynx, but if there is thick meconium, okay? If there is thick meconium, deliver the baby, endotracheally intubate, and suction the airway. Only for thick meconium. Thin meconium, you don't do anything, because intubating the baby can cause more problems. Okay? You guys have the distinction here? If it's thin meconium, deliver the baby and suction them. If it's thick meconium, deliver the baby, intubate the baby, and suction. Only for thick. Okay? Does that sound okay for you guys? Thick, intubate, suction. Right. Thin meconium does not cause meconium aspiration syndrome. That is correct, Sadaf. Thick meconium does not really cause meconium aspiration syndrome. And then your you could theoretically cause more problems by intubating the baby. It's just not worth it. We've learned that now. Okay? Only intubate for thick meconium.